So, good evening, everybody. I'm Dr. Warid Altaf. I am from Sancheti Hospital, hand and upper limb surgeon. Uh, at this outset, I would like to thank the Al Azhar University, which I recently came to know that is one of the oldest universities in the world for giving us this opportunity to present our work and discuss upon this important topic. So, I'll be talking on missed injuries in the upper limb. So the learning objectives, or in other words, what missed injuries can be there. I have categorized it into a couple of groups. So what a surgeon can miss. For example, this is a AP and lateral view of the wrist joint, in which we can see that there is a fracture in the carpal bones, and if you see the lateral view, there's a complete perilunate transcaphoid perilunate dislocation. So most of the times, even reported in the literature, we have seen that there is these kind of injuries are missed if a proper x-ray is not taken, or if we only look at a single x-ray. So concomitant injuries, very important, like when we are looking at an x-ray of a certain fracture, what other things we should look for, that is also very important, which a surgeon should have at the back of his mind. Like for example, there is a fall on an outstretched hand, and there is a fracture of the lower end of the radius. So one should always look at the proximal part of the radius, or the elbow joint. So as a rule, we should always see one joint above and distal to the fracture in order to miss any injuries. So something like this, like this patient had a fall on an outstretched hand, but if you see, there's a fracture of the lower end of the radius, and along with that, there is a fracture of the radial neck also, like what we call is that an Essex-Lopresti injury. So a concomitant injuries, we have always to be kept in mind that there can be an injury at the other part of the bone as well. Sometimes when treatment is inappropriate, like certain fractures have been fixed in an inadequate manner. And also we'll discuss the trash lesions. I'll come to this later on. Like sometimes we see that an x-ray is a normal, especially in pediatric injuries around the elbow. The x-ray looks somewhat normal, and we just say this is a trash. We just throw that x-ray away, and certain times these kind of injuries can be missed. So coming on to first case, this is a patient as a 48-year-old male, had a road traffic accident, had a humerus shaft fracture which was fixed very nicely, and with a locking compression plate. But what you see in these x-rays are pretty inadequate. Even if we see from first to the last ABC, we are not seeing the elbow joint clearly in any of the x-rays. So at 8 weeks post the fixation of this humerus, the patient had grossly restricted pronosupination, and otherwise he had a good elbow flexion and extension, but pronosupination was restricted. And then we suspected that something is wrong in the elbow, and once the elbow x-ray was done, and that there was a comminuted radial head fracture which was initially missed. So that again tells us that it's very important to do an x-ray of the entire bone, which should have the proximal as the distal fracture seen there. And then this patient was later on operated at 8 weeks with a radial head replacement was done. So this is, I begin with this one of a simple case in which we can miss some fractures. And even in literature, it has been suggested, it is quoted many a times, that humeral shaft fractures are associated with radial head fractures, or humeral shaft fractures are associated with the AC joint disruption or the clavicle fractures. So whenever we are seeing such kind of patients, we should always have to examine clinically whether the distal joint, the proximal joint, are involved or not. So basically, when these fractures are missed, is most of the cases are high velocity injuries. So whenever we see some major injuries, something like this, cervical spine injuries, long bone fractures, chest injuries, abdominal injuries. So most of the focus goes on to these kind of injuries when we have to stabilize the patient. And that is why, according to the ATLS protocols, the secondary survey is very important. So once the primary thing is stabilized, patient is made stable, and then a secondary thorough survey should be done to look for all the different skeletal injuries which would have been missed at the primary time, at the primary injury. So what are the commonest missed injuries we have in the upper limb are radial head and neck fractures, scaphoid fractures is very common, lunate and perilunate dislocations, Monteggia fracture dislocations are commonly missed, especially in pediatric age group, metacarpal fractures and dislocations, transcaphoid perilunate fracture dislocations, CMC dislocations, posterior dislocation of the shoulder, sometimes greater tuberosity fractures are missed, AC joint dislocations, as I said, and trash lesions. So these are the commonest injuries which are usually missed. This is an example of a 28-year-old male who had a road traffic accident, had an open pelvic injury along with a comminuted compound tibia fracture. So at 3 months post fixation of all these injuries, he came with a wrist pain, and you can see a deformity in the wrist joint. So once the X-rays were done, you can see there is a complete dislocation of the carpometacarpal joint of third, fourth, and fifth. And we got the CT scan done to see, and you can see that the joint is dislocated. However, he had a good range of motion in the wrist joint, but the CMC joint was giving him trouble. There is pain, deformity. So in this case, an open reduction and osteotomy of the third CMC joint was done, and it was reduced. So you can see in this middle picture that all the three bones, this is the third, fourth, and the fifth metacarpal base can be seen. This was completely dislocated and it is overlapped about a centimeter. So very difficult situation that to reduce these is very difficult. Sometimes we have to do a primary fusion in such kind of injuries. So this is how it looked, and it was open reduced and fixed with multiple wires, maintaining the alignment. And that was his function at 3 months. So again, a 40 years old male patient, he had a road traffic accident, had a compound tibia fracture, which was initially managed and fixed with an external fixator and a nail for a fibula. The alignment looks pretty good. Again, this patient had a chest injury and a hemothorax. So at 3 months, this patient again came with a deformity, with a subtle deformity in the wrist joint. And once the X-rays are done, you can see that there is a comminuted fracture of the lower end of the radius, and which is dorsally displaced. So typically like a dorsal Barton kind of a fracture. So this patient had a severely restricted palmar flexion and very painful range of motion. So again, at 3 months, it is difficult to fix these kind of injuries, and but they are grossly disabling the function of the hand. So now how to plan now? You have to sit and plan how to fix these injuries, how to correct these deformities. So if you see, there is the problems here are that the whole carpus along with the metacarpals and hand is dislocated volarly. So there is a gross dorsal subluxation in the wrist joint. The radial height is significantly reduced. So there's an articular fragment which is tilted backwards, and it is comminuted. So that dorsal tilt is there. And also the radial styloid fragment seems to be a separate fragment. So these are the problems which have to be addressed and planned accordingly. So this is how probably we'll have to go dorsally and do an osteotomy somewhere there, and restore the articular tilt along with the radial height and fix the radial styloid, and probably go through. We decided to go through the dorsal approach, did an osteotomy through that fracture site, intraarticular osteotomy, and then this was fixed with two plates from the dorsal side, along with an Herbert screw for the radial styloid fragment. So so intra-op imaging again is important. These are the oblique views to see whether all the screws have got hold of the small fragments, one of the fragment which was on the volar side, and a restoration of the articular cartilage. So this is an intra-op picture, what how the EPL tendon is taken out, because most of the times what we see when with these dorsal plates, there is problem with the tendons. So especially the extensor pollicis longus tendon, which may get ruptured later on because of the continuous friction along with the hardware on the dorsal side. So you can make a small flap of the extensor retinaculum and just pass it beneath the tendon of the EPL and then suture it back, so that this remains outside the, and there's not, it's not in direct contact with the metals. And now you can see this is the post-op X-ray in which the alignment is back. It is the carpal and the radius. The radial height is maintained. Most importantly, the volar tilt of 7 degrees, which has to be there, which was reversed, has to be reverted back in order to get the good palmar flexion back, and the articular surface, which was again tilted backwards. So this patient had a very good function at the end of 6 months of follow-up with a good grip strength and pinch strength as well. So this is another case of a 55 years old male. He had a fall on an outstretched hand. So commonly we see these upper limb injuries are always, most of the times, if not road traffic accidents, they are fall on outstretched hand. So this, he had again had a dorsally Barton kind of a fracture, comminuted fracture. But again, why I'm putting this X-ray is that initially we had this single X-ray, and we decided to go and fix it with the multiple K wires and restore the intra-articular reduction. But again, if you see, the patient continued to have pain in the elbow joint, and retrospectively seen, and then there is a comminuted fracture of the radial head and neck. So these fall on outstretched hand are always have to be checked for Essex slow pressure injuries, and in this case, this was converted into an above elbow cast because the fracture did not look much displaced. There was not much shortening of the radius, and this was converted into an above elbow cast for 6 weeks. So this is a 40-year-old male, again a fall on an outstretched hand 1 month ago. He came with numbness in the hand, severe pain and nocturnal acroparesthesia, numbness, especially at the night, grossly restricted wrist movements, and loss of dexterity. So this is an X-ray. So if you see the X-ray, there is, if you see AP view, there is break in the glutealized lines, and if you lateral view, if you see, there is clearly there's a lunate dislocation on in the volar side. These kind of injuries we are seeing very commonly at our center, being missed elsewhere, even sometimes by the orthopedic surgeons and by general practitioners. So this kind of an injury was 1 month ago. So actually he presented with a carpal tunnel syndrome. So once he noticed numbness in the hand, night pain, typically in the zone of carpal tunnel. So we found that this patient had a dislocated lunate. So at 1 month, 6 weeks, it is always difficult to fix these fractures and reduce these fractures. So most of the times you need dorsal as well as volar approach. Initially go with the dorsal approach, try to reduce the lunate. If it comes back well and good, if not, then go with the volar approach and again reduce the lunate back into its place, and also do the carpal tunnel release from the volar side, which is very important. Even if we have reduced the lunate from the dorsal approach, it is mandatory to do a carpal tunnel release from the volar side, of course, in order to get rid of the symptoms of the carpal tunnel. This particular was fixed with 2K wires going from scaphoid to lunate and from tricuterum to lunate. And the wires were there in for 6 weeks. This is at 1 month. So at 3 months, you can see the wires have been removed, and the patient had a reasonably good function. So he had the main important thing, what was bothering him was his pain of the carpal tunnel syndrome, and his joint movements were restricted. So he got back pretty well in that. This is probably one of the commonest injuries which is missed in the upper limb, especially in the hand and wrist. That is the scaphoid fractures. Getting a proper view is very, very important. So if you see this X-ray, this is a X-ray PA and lateral view, and you can see there is a fracture of the waist of the scaphoid. But if you get a proper ulnar deviation view, and then you can see the whole complete displacement of the fracture. So maybe sometimes getting these X-rays, you can miss the scaphoid fracture. So whenever we are suspecting there is a tenderness in the anatomical snuff box on the radial styloid area, it is always better to get an ulnar PA view in ulnar deviation. And in literature also, it is mentioned that the scaphoid fracture is missed maybe in around 20 to 30% of the cases, especially when there's a concomitant upper limb injury or a polytrauma patient. So this X-ray is again an AP view. If you see this X-ray, maybe somebody might label it as a normal X-ray, but if we see clearly, there is something wrong here. The alignment of these carpal bones is not looking normal. There can be a scaphoid fracture here, or there can be some other carpal bone injuries. So commenting on one X-ray again, especially sometimes in polytrauma patients, we get only one X-ray, get only AP views, and not getting the lateral views done because the patient is maybe not stable enough. So that is why secondary survey is very, very important, and getting proper X-rays are also very important. Maybe not at the time of injury, but once the patient is stabilized, getting at least two views, that is AP and lateral view of that particular area. So if you see the lateral view here, so this is a typical transcaphoid perilunate fracture dislocation. So again, maybe looking at one X-ray would have been missed. And the problem with these injuries is that once they are delayed, it is very difficult to reduce them back. Getting back that function is also a very big challenge. So if you draw these Gullila's line, the first line may look normal, but the second and the third line, that is disrupted. So that again, on a single view also, we can make out that, yeah, we need another lateral view here because something is wrong there. So these are the Gullila's line that help us to see the carpal bone alignment. So for scaphoid, the scaphoid series, that is the four views. These four views are very, very important. You can see that this is a PA view, then a PA view in ulnar deviation, a lateral view, and a semi-pronated oblique view is very important. So semi-pronated oblique view is slight pronation of the forearm, and then radial deviation. You will get the whole length of the scaphoid. So you will probably not miss any fractures if these four X-rays are done. So this is a 35-year-old male. He had a 4-month-old trauma. Again, it came with restricted range of motion and pain in the radial styloid area, and you can see there is a distal pole fracture of the scaphoid can be seen here. So in a lateral view, you can clearly see there is a fracture line. So you don't need probably a CT scan to diagnose that. But then in a lateral view, if you clearly see, this is the proximal and the distal pole of the scaphoid. So that you can see the flexion deformity, and the fracture gap is clearly seen in the lateral view. And you can also appreciate that the lunate is tilted backwards, what we call it as a DC deformity, which we see in chronic non-unions when the carpal alignment is not normal. So the lunate starts to go on the posterior side, there is hyperextension of the lunate. So that is what is seen, and which can be measured if, by taking a scaffold lunate angle along the long axis of the radius. So the problems here again are now flexion deformity is there, there's a disc deformity, and there's a gap at the fracture site. So these all have to be addressed in order to get a good function, get a first challenge is to get a union there, because scaphoid is always notorious for non-unions, and also correcting the DC deformity in order to get a better range of motion of the wrist joint. So the CT scan in this case, you can see there is a distal pole fracture is there. You can see it is actually an oblique kind of a fracture which starts at the distal pole and goes into the waist of the scaphoid. So serially seeing all the CT cuts again is very important when we are planning to fix these kind of a fractures. You can see all the coronal cuts and the sagittal cuts serially, and then you plan your surgery accordingly. So this you can see there is it's actually starting at the distal pole going on to the waist, and in the sagittal cut you can see how the proximal pole is gone into hyperextension. So the proximal pole and the lunate, they will tilt backwards, and the distal pole goes into flexion. So that's how it collapses, and that's we call it as a humpback deformity of the scaphoid. So there's a pseudo arthrosis kind of a thing which has formed here. So this was treated the plan. This was planned for an open reduction and anterior wedge grafting in order to correct that flexion deformity and the shortening what has happened in the scaphoid. So volar approach, once you go down to the fracture, you can see this is the fracture here, and one important tip uh, how to actually see the fracture fragments and debride it properly is that we can put two K wires, one in the proximal pole and another in the distal pole of the scaphoid, and then joystick these fragments like what is shown in the right side. So once you have opened up the fracture side, you can actually see the defect, and you can also correct the flexion deformity. So it's usually a triangular kind of a defect which is seen. So that is how you need a big iliac crest cortical graft, corticocancellous graft, to fill in that void. But before filling that graft, it is mandatory that we should debride the fracture ends very well, and this till we see that intraoperatively we see some bleeding from both the fracture ends, because avascular necrosis is also again another problem which is seen in scaphoid fractures. So this joysticking of fragment is very important. You can see how initially the wires look crisscross, and when you open them, you can open up the fracture site. So another important thing is that we always use a high-speed burr to because it's a small bone. You cannot use big instruments or osteotomes to debride the fracture ends in order to see that punctate bleeding. So we use a high-speed burr, and on either side of in both the fragments, you just remove the fibrous tissue, remove the dead necrotic bone, whatever is there, till you see that bleeding. So this is usually a corticocancellous graft, which is triangular in shape, is used to fill that defect. Once you can see in this picture, the fracture ends look pretty decent, bleeding, and then a triangular kind of a graft, usually a little bit oversized. Whatever you measure, maybe you can go a few millimeters on a higher side, and then you take that graft and punch it inside, so that it is very well fixed inside. It is jam packed. You just give a gentle traction to the thumb in order to open the fracture site, and then you push that graft inside and hammer it with a very small mini bone punch and hammer. And the whole idea is that the graft should be interposed in such a way that it gets snugly fitted in between these two fracture ends. Most of the times, even some surgeons, they don't use any kind of an internal fixation after putting this graft, because if it's a cortical graft, a little bit oversized, it opens up the one of the fracture site and it gets jam packed Uh, and this is how the C-arm picture looks at that point of time. So there is this is the graft, and this is the distal pole, and this is the proximal pole and the waist of the scaphoid. So checking the stability of the graft is also very, very important. So once you have fixed the graft, you have hammered it inside. So before doing an internal fixation with K wires or screw, whatever you want to do, but the stability of the graft, so checking in wrist flexion, extension, and ulnar and radial deviation, it is very important to uh, check the stability of the graft and then go ahead and fix it, because that fixation is just adding more stability to your fixation what already is there. So that is important. So in this case, this was fixed with a Herbert screw and an anti-rotation wire. You can put an anti-rotation wire because sometimes in non-unions uh, there is a chance of popping out of the graft. So the graft may pop out because it's a cancellous graft. The position is the shape of the scaphoid is something like a peanut. So sometimes with the movement you see that the graft pops out intraoperatively. So it is advisable to put 1K wire, and along with that you can put a Herbert screw, and again check the stability of the graft. Uh, After that. So this is the 4 months follow up. You can see the fracture is healed nicely. That graft is getting absorbed, and the sclerotic part is seen on the X-rays in both AP and lateral views. There is some amount of DC deformity which is still there, but then the fracture is healed, which is more important, and the patient had a very good function. So that is about the scaphoid fracture, which is commonly missed. So I'll quickly go on to what we call them as trash lesions. Most of the pediatric orthopedic surgeons must be aware about this term. Like what they have coined is that they see an X-ray, just throw it in the dustbin like this. There's nothing wrong in it. But there are many pediatric injuries which are missed. Many a times they are missed. So looking at them, how to read those X-rays in order to avoid missing those injuries is important. So this is a young girl who had come with uh, a function something like this. So she was initially treated elsewhere, and grossly restricted elbow movements and grossly restricted supination. So something definitely wrong in the elbow. So you can see this lateral view is the radial head is completely dislocated anteriorly. So this is a Monteggia fracture. So normally the radiocapitular line, as all of us know, should pass and bisect the capitulum in any arc of motion of the elbow joint, in any flexion or extension in EP or lateral view. It goes through the center of the capitulum. So but in this is how actually it should go, but it is going completely out. So just looking at the axis of the radial shaft, it is you can get an idea that there is something wrong, and this is a radial head dislocation. So this is what is known as a McLaughlin's line, a very important line which I recommend should be seen in every pediatric uh, elbow injuries. Another important thing is like you see this X-ray. This is known as a Mubarak's line when you join the ulnar distal end of the ulna and the proximal end of the ulna. So normally this line is a straight line going through the shaft, and whenever there is an anterior bowing of the ulna, what we call is an anterior or a plastic deformation of the ulna, so this kind of a picture is seen. So there is a gap between the shaft of the ulna and this straight line that is known as the Mubarak's line. So this is the initial stage. So in these injuries, one has to be carefully, one has to look for the radial head dislocation or not. So because this is the initial force which develops, there is a plastic deformation of the ulna, and subsequently when force increases, and there is the anterior dislocation of the radial head, which we call as a Monteggia fracture. So when there is an ulna fracture along with the radial head dislocation. So these injuries are very commonly missed. So this particular patient was treated because it was a delayed presentation. So it was treated with an corrective osteotomy and fixation with a plate. And you can see that is the restoration of the radiocapitular line. This is again a pediatric patient which was treated elsewhere initially with an above elbow cast. Some kind of a splint was given, so probably it was diagnosed with an ulnar fracture. So and the treating surgeon had thought that this is an undisplaced kind of an ulnar fracture and it will be healed in some kind of a cast. So but if you see clearly in both the x-rays that it's not just an ulnar fracture. uh, in this view also we can see that the distal end of the radius is also probably fractured here. So at 1 month, this was the position. So the treating doctor felt that everything is fine. This is 1 month post injury. The fracture probably looks healing. But at 2 months, so he continued the plaster for another 1 month. So at 2 months, actually a proper X-ray, a lateral view was taken, and this is what you see at 2 months. So the radial head again is dislocated anteriorly. So this was a Monteggia fracture, a variant actually with the lower end of the radius fracture. So this radial head was initially missed from the day of injury. So this is again why I'm saying is that X-rays and reading of these pediatric X-rays is very important in order to miss these injuries, and treating them down the line at 2 to 3 months becomes very difficult, and it obviously has its implications on the functions of the uh, patient definitely. So this is 2 months again. So this is how the patient came to us at 6 months down the line. The ulnar fracture is completely healed, remodeled well, and the radial head is dislocated anteriorly, anterolaterally it is dislocated. So again, this is the same McLaughlin's line which I have told you earlier, that it can be checked in AP as well as lateral views, oblique views, whatever views. This line should cross the capitulum when we are taking it from the long axis of the radial shaft. So this was again treated with a corrective osteotomy of the ulna, and which helps in relocation of the radial head back into its place. So this is a 7-year-old female. If you see, this is an AP and the lateral view. And this is the internal rotation view. This is basically a lateral condyle fracture. So lateral condyle fracture again are very notorious fractures. One is that they are missed because it's very difficult to diagnose on plain x-rays. And second thing is they go into non-unions because of the muscle pull and the pathomechanics of that fracture, and that leads to, so in internal oblique view and an AP view in internal rotation of the shoulder is very important, because in this you just you cannot see, and you can see a thin fracture line here. So that's very important, because inherently these fractures are unstable, and then they subsequently go into non-union and cubitus valgus kind of a deformity. So this is another X-ray of a 6-year-old male. You can see there's a suspected fracture, probably maybe there clinically there's a tenderness there. Um, but if you get an internal oblique view, this is an internal oblique view. This is a clear-cut fracture you can see. So other ways of diagnosing this is doing an MRI, and an MRI can tell you whether there is a fracture or not. But getting a proper view of the X-rays is very important. So this had ended up in going into a non-union of the lateral condyle, which we commonly see in adults. So internal oblique view is very important. You can do an intraoperative arthrogram by which you can inject a dye inside the fracture line and see whether it is going into the joint or not. If the dye is going inside the joint, which you see on a C-arm image, that means it's a complete fracture. So that again tells us that it is unstable and it needs fixation. It cannot be treated in a plaster. And also the pattern of the fracture line. If the fracture line is broader towards the joint, that means it's a divergent kind of a fracture line. That means it is an unstable fracture, needs fixation. If it's a converging type of a fracture line, that means probably it is not going into the joint. So there are certain ways of diagnosing that, and arthrogram is very important investigation. So I think the take home message is we should take adequate x-rays and take proper x-rays in other ways, proper views of the x-ray, especially in scaphoid fractures, in elbow injuries, pediatric elbow injuries. CT and MRIs can be done to look for occult injuries. Sometimes, we are not sure still whether there is a fracture or not. Especially in scaphoid, we have to do CT scan to see whether there is a fracture, or we have to do an MRI to see whether the proximal pole or the proximal fragment is, whether it is viable or not. Look for the concomitant injuries. Like I told you initially, whenever there's a fall on an outstretched hand, we should start right from the clavicle, from the AC joint, clavicle and humerus elbow, and go to the wrist and check clinically whether there is tenderness or not. If there is, we get an x-rays done, because these kind of injuries, clavicle, AC joints, they are very frequently missed by a simple fall on an outstretched hand, because most of the focus goes onto the distal and radius fractures, or the elbow, and the shoulder part is somehow missed. Provide rational treatment at the time of initial presentation. So thank you very much.
Thank you, Dr. Walid. This is a very informative lecture. I think missed injuries is a big problem, not only in the upper limb, but in all the body. We're facing many cases of missed injuries, and we have a thesis of master degree about missed orthopedic injuries and how much this is valuable. So to decrease the missed injuries, I think we need not only the first examination of the any bullet trauma patient, but second look and tertiary look. So any patient facing a big problem of severe injuries like you present, we need the first examination at the AR, and then second look by more senior staff, and then tertiary look. Tertiary look may find even missed toe injury or finger injuries or something like that. I thank you for this informative lecture. If
Hello.
Hello. Yeah, I think
Dr. Walid, thank you very much for your presentation.
Thank you. My pleasure.
But I think before we said there is missed injury, we have to follow the rules. We know, all of us, any X-ray has two joints, distal and proximal to the fracture.
Correct.
And any X-ray for any limb should be AB and lateral at least.
Absolutely.
If we do the rules, we stop some missed injuries, or reduce this missed injuries. But I have commented, please, in case of fracture distal radius with neck radius, proximal and distal radius, did you guarantee about the interosseous membrane? Absolutely, there is injury of the interosseous membrane.
It is always there. It is unless proved otherwise. I think whenever there is a fracture of the distal end of the radius and the proximal end of the radius, the interosseous membrane has to be injured. There is question about that.
The question is, should be manage the fracture conservative, or we must reduce both distal and proximal to avoid Essex-Labrust syndrome or shortening of the radius? And
very good question. I think if you see the current literature and the current trend, what is going on, these fractures should be fixed properly, the distal as well as the proximal. That is what the current literature suggests. because later on there are always issues with the chronic pain in the wrist joint. There is some migration of the radius proximally, and the biomechanics of the entire forearm changes. So ideally, these fractures should be fixed. A radial head, if not fixable, may be replaced, but the height should be maintained.
Yes, I see your case one. You managed conservative by cast for the proximal neck radius.
We did conserve that because one, it was a bit delayed presentation, and the alignment looked somehow all right. But again, if you I would still suggest that these kind of fractures should be fixed and mobilized as early as possible.
There is another case in plastic deformation of the ulna with dislocation head radius
Right.
after the post-operative X-ray showing shortening of the ulna at the wrist.
Absolutely. Yeah.
Did you make shortening during correction of the deformity of the ulna, or what's the cause of shortening distal ulna?
You are asking about that case in which that osteotomy about the this thing is done?
Yes, one case, one of your cases.
Yeah, there is an angulation osteotomy which
Yes.
is done in that case, which inherently leads to a little bit of shortening of the yeah, because that is the only way the radial head pops back into its place, because it was a chronic I think at around 2 to 3 months. So otherwise it's very difficult to get and maintain the reduction of the radial head in place.
And if the radiuses didn't spontaneously reduce after the osteotomy of the ulna, what we can do?
Sorry, again, I could not hear that properly.
If the head radius didn't spontaneously reduce after shortening of the ulna or correct osteotomy of the ulna,
Right.
what we have to do?
If it does not reduce, then see, you have to do an open reduction of the radial head. Most of the times in chronic cases, when we do the osteotomy of the ulna, the radial head falls back into its place, even at 2 months, 3 months, 4 months. But even if it is not, you have to take a separate incision like a Cocker's approach for the radial head, and then reduce that and reconstruct the annular ligament, or by any means you have to keep it reduced. You have to try to reduce that radial head. Most of the times it is reduced when the ulnar alignment is maintained. So that's an indirect reduction of the radial head basically. So it is most of the time it gets reduced.
Thank you very much.
Okay.
Thank you, Dr. Wareed. Very interesting lecture and very informative and very nice cases. Really well enjoyed watching this presentation.
Thank you so much. I'm very glad. Thank you.
We are very glad to host you thus as a guest speaker today. So we introduce our friend Dr. Muhammad Mawad. Is a lecturer of orthopedic consultant spine surgery in Al-Azhar University, to speak about the missed spine injuries. Hopefully you can stay with us for a while. I know it's too late already, but
okay, no, I'll be there till the end.
Okay, as long as you can persist to stay, please. Okay, thank you. Yes, Dr. Muhammad, please go ahead. Dr. Muhammad Mawad. So unmute yourself, please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good night, everybody. Our talk about missed spine injuries. Start, sir?
Yeah, sure.
Motor vehicle crashes, falls from height, interpersonal violence contributing to more than 12,000 spinal cord injuries each year in the United States. So missed spine injuries may lead to marked disabilities. Missed spine injuries may be cervical or thoracolumbar injuries. The most common cause of missed spine injury, apart from less experience from the surgeon or the doctor, is insufficient imaging of the patient, or misreading of the imaging, or accepted quality imaging. We start with thoracolumbar spine fractures. Many of these fractures associated with extraspinal injuries and are subtle, further contributing to diagnostic delay or misdiagnosis. Careful and thorough workup of the multi-trauma patient with dedicated spinal imaging is necessary to identify these issues. Thoracolumbar spine fractures occurs in 4 to 18% of blunt trauma. Victims are often associated with major concurrent injuries like head, chest, abdomen, pelvis, and extremities as a part of polytraumatized patient. Fracture of thoracolumbar spine may be difficult radiographically, so misdiagnosis raises the incidence of neurological deficit from 1.4 to 10.5. So neurological injury in misdiagnosis 10.5 compared to 1.4 when diagnosis at the time of presentation. Some important anatomical factor: thoracic T1 to T10 more stable, articulation of rib cage and sternum. So if trauma here, like high energy trauma, may lead to fracture dislocation. Thoracolumbar transitional zone, this is transitional zone, high liability to injury, less stabilizing effect of the rib cage and sternum. Transitional zone between thoracic kyphosis and lumbar lordosis, fast orientation change from dorsal to lumbar. Lumbar L3 to L5, lumbar lordosis balances thoracic kyphosis, such that axial loads are propagated through instantaneous axis of rotation, located at the posterior third of the vertebral body. As a result, excessive compressive load produces perist fracture, which predominant in this region. So, X-ray like this, plain X-ray chest, posterior anterior view. No, we can't say in this fracture spine, but we show widening of the mediastinum and aortic arch. But with CT, we see like this, fracture dislocation, dorsal spine. So X-ray alone will not be sufficient to diagnose a case like this, so must care. In case like this, we see the fracture of the anterior column with the posterior column intact. Here, after neglection, the patient has no treatment. We see more compression occur from wedge fracture. This AP plan, the only finding we found in the X-ray is the widening of the interpedicular distance. And this is the CT, sagittal, and the axial of the same X-ray. So X-ray alone will not be sufficient to diagnose spine injuries. Patient like this at ICU, we can suspect here fracture at the superior end plate. When the patient accidentally CT abdomen was done, show fracture of the spine. And this is CT of the same patient when we do CT for the spine, not for the abdomen. And this is the sagittal CT. The patient took conservative treatment, and after 15 days, the X-ray was like this for the same patient. So the problem of neglection have high cost to the surgeon, to the patient, to the community. In this, we must to know this AP and lateral view. There is overlap of the pedicle, rotation, interspinous disappear here. In the lateral view separation, this is must to know. This is chance type fracture, and this type of fracture is easily to be missed. In axial CT, this characteristic for chance fractures, the shadow absence at one side of the pedicle and the facet orientation is characteristic of chance type of fracture spine. And this is X-ray and CT of the same patient. Here we can see the injury of the posterior ligaments extension band in chance type fracture. Misdiagnosis of cervical spine. Correct diagnosis of cervical spine injuries is still a common problem in traumatology. The incidence of delayed diagnosis from 5 to 20%. For optimal examination with suspected cervical spine injuries, complete set of proper radiograph with functional view. Secondary evaluation may need for CT or MRI. So diagnostic algorithm in alert patient when the patient oriented to view the spine radiographically if complete normal, dynamic view, negative clinical assessment, normal clear, positive go to experienced surgeon. From the start, we can see if positive radiology to do CT or MRI further assessment. If suspicious, experienced surgeon to more assessment. So don't detect the patient is normal from X-ray alone. Diagnostic algorithm in patient with alert mental states, which is completely difficult. 3-view spine radiography, if complete normal, negative or positive. So if negative, we must admit the patient for further assessment also. And this X-ray lateral view of the patient with trauma, we can suspect or not suspect an injury. When the patient go to complete his radiography, this was not complete paraplegia. From the start, this is the region at 5-6, complete separation with moving or with bad moving or incorrect positioning of the patient. His presentation, male patient 32 years old, presented by first degree of fracture of both neck, fixed by interluminal tibia with debridement under spinal anesthesia. And this cases we do by ourselves. This X-ray, the patient fixed by nail tibia. Deterioration of neurological condition after recovery of the patient. Re-examination. This is the CT, sagittal and coronal of the same patient. The patient after operation deteriorate from the start, has this fracture, neglected, anesthesia gave him spinal anesthesia with flexion of the trunk, more injuries to the cord, come with neurological affection. This is CT of the same patient. This is axial CT. So we posterior approach, fixation with reduction of the fracture, and the patient improved. This is X-ray and CT of the same patient. Another cases of cervical spine, as here, this may be missed from genuines, so we must talk experienced surgeon, as we see C12. The patient non-fluxed cervical fusion. Another cases, this X-ray, we can see fracture, neglected as the patient at ICU. This is CT of the same patient, fixed by plate after 20 days of neglection. This X-ray, can anyone say there is abnormality in this X-ray apart from the patient had ankylosing spondylitis? We can see this X-ray, but with this MRI, do you see the difference of the patient? This MRI of the same X-ray of this patient. Do you see complete dislocation, transection? The patient done with posterior approach reduction, with fixation. This is facet dislocation, unilateral facet dislocation, which is one of the most common cervical spine injuries. This is of patient with partial humerus, neglected cervical, and coming later on after 2 months with pain. This is CT of the same patient, MRI. So in some cases like lumbar fracture like this, neglected from 4 months, what can we do? This X-ray, the patient come neglected with neurological manifestation start from kyphosis. And this is CT of the same patient. So we done spinal osteotomy and correction of the patient, but more advanced surgery, more extensive surgery, more liability of the patient to complication. So the cost when delay or misdiagnosis will increase for both the patient and the surgeon. And this is female with polytraumatized. I think this, I heard this female, 18 years, was colleague at Al Azhar University. She has both bone leg, fracture femur contralateral, fracture proximal humerus, fracture distal radius. And this type of injuries, if this X-ray is enough, this CT, do you see the injuries? So in cervical spine, we can't exclude injuries except after complete assessment, even. This is a patient post-fixation with reduction. Take-home message: neglected spinal injuries secondary to overlooked diagnosis may result in serious medical and medico-legal problems. Overlooked spinal injuries are most frequently seen in unconscious or intoxicated patients and in polytraumatized patients with distracting remote injuries. There are 4.5 times more frequent cervical compared with the thoracolumbar spine. The most common cause is failure to obtain radiography. The most serious consequence of overlooked spine injuries is progressive neurological deficits. More frequently, they result in progressive deformity, persistent pain requiring surgical intervention that most likely could have been avoidable, often with an unsatisfactory outcome. Untreated or adequate treated spinal injuries with lead presentation are more often seen in developing world. So early diagnosis, adequate management to avoid late sequelae with comorbidities. Thank you.
Thank you, Dr. Mohammed. I think it's a very informative lecture, and thank you all. We came again for any polytrauma patient or unsuspected patient must be seen by more than one or by more senior staff, because most of negligence or most of missed injuries, I think, from rapid examination or from facing the patient with junior staff. So the very important lesson to learn for all of us, especially junior colleague, you must don't exclude any specific injuries, especially large injuries like injuries in the spine, in cervical, in the dorsal, in the lumbar, in upper limb, in the lower limb, even in the fingers, or even in the pelvis. We're facing many cases of complex injuries, especially in comatose patient, or especially in patient with polytrauma in ICU. So examination first time and the examination is very important. Any question, please, or any comment for this lecture?
I have one question.
Okay, go on.
Yeah, so a very nice presentation. I think we have to stick to the basics again. That primary survey and secondary survey is very important to see for these injuries. Go back to the patient again and examine by some senior person is always advised. So I want to ask that these odontoid fractures, sometimes they are missed, the fracture of the dents, and later on the patient comes with some myelopathy or some gait instability or UMN type of a picture. So what is your take on that? If there is a fracture of an odontoid process and then the patient later on comes with some neurological problems, so how do you deal?
Yes, we're facing about 3 cases in the last year for neglected odontoid. One of them, Dr. Mohammed presented.
Right.
Yes, if this fracture is associated with myelopathy, we can do. We need to fix this fracture and we decompress. Most of cases or is there way to do posterior occipital-cervical fusion if the odontoid fracture is stable enough to do odontoid fixation via anterior approach is enough, but sometimes you can need to excise the fragment of the odontoid fracture through the occipital through buccal approach, open mouth technique. So we need to go for two goals. The first is decompression, even with excision of the fragment of the odontoid, and fixation, which is carried out through the posterior approach, is better. Yes.
Right.
Dr. Abdullah Busenna, have you a comment? Dr. Isavi?
Yes.
Yes.
Yeah. Thank you.
Yeah, thank you. So We go back for hello.
I would like to thank Mr. The
Professor
Indian,
Walid.
our guest, yes, for
Dr. Walid,
his
yes.
yes, for his excellent presentation. Actually, the most well-known facts in missed injuries is commonly in polytraumatized patient and in unconscious patient or in polytraumatized bone. For example, the femur, when there is fracture shaft, fracture neck, fracture condyle, and so on. But in the wrist joint and in the upper extremity, the patient is well alert, and he came with painful wrist or painful upper extremity, and he is quite alert. But there is very common missed injuries, as said by Professor Walid in his lecture. I would like to ask him again if there is any ligamentous injuries important. For example, common missed scapholunate dissociation and in the common missed injuries in the distal radioulnar joint. Have you faced these injuries or not, and how to deal with neglected cases like this? This is my first question. The second question, what to do in case of acute scaphoid fractures if there is no visible x-rays, if there is no fractures seen in the x-rays, what to do? Do you splint them and re-examine after 2 weeks by another x-ray or not? And what is the image more valuable in this state, in this situation? Is it the CT or the MRI?
Absolutely.
Thanks.
Yeah. Very good question. I'll come to the first question, which is that scapholunate injuries or the DRUJ injuries.
Yeah.
Very commonly missed. Especially, I'll come to the scapholunate injuries first. Acute scapholunate injuries, if we don't take the proper X-rays or clinical examination, very commonly it is missed. So the ideal X-ray is a clenched fist view, an AP view or a PA view in a clenched fist manner, and then you see that dissociation between the scaphoid and the lunate, which what we call it as a Terry Thomas sign. So always in acute injuries, even if we see a Terry Thomas sign on an X-ray, we still manage it conservatively. If it is a fresh injury diagnosed right at the maybe within a week or so, we give a short arm cast, that is a below elbow cast, for at least 4 to 6 weeks. That is for acute scapholunate injuries. If it is chronic, maybe down the line 2 to 3 months, and now you are seeing that gap between the scaphoid and lunate, then that is a concern because they may inherently are unstable, may lead to carpal instability, and the capitate abuts in between the gap, and yeah, there is what is called as a slack wrist, scapholunate advanced collapse. So to prevent that, to prevent the arthritis, radiocarpal and intercarpal arthritis, then it is recommended to repair or reconstruct those ligaments, which is best done by arthroscopy. And arthroscopically, you can diagnose them very well, and you can do what's called as a dorsal capsulodesis and repair of the scapholunate ligament. Even at 2 to 3 months, it can be very well done. Arthroscopically repair the ligament by putting some anchor sutures. Or if it is more neglected, maybe 6 months, 8 months, then you have to do an open repair of the scapholunate ligament, which is done from dorsal plus volar approach or either from the dorsal approach only. So they have to be treated because otherwise they end up in the arthritis of the wrist joint. So that is about, I think, the scapholunate injuries. Same is the case for DRUJ injuries. DRUJ injuries, acute injuries, they very well heal in conservatively. That is splinting or cast. But this cast has to be above elbow cast, which with the forearm and wrist in supination, because that is the position where the interosseous membrane is stretched completely and the DRUJ falls back into its normal place, alignment, and which in acute situation is always it heals. And in chronic cases, what frequently we do is an Adam Burgess procedure, we call it as, that is a ligament reconstruction of the DRUJ. We take a palmaris longus graft and make interosseous tunnel through the ulna and the radius, and in a figure of 8 manner that is reconstructed. That is in chronic DRUJ injuries. Both are very important because the end stage is otherwise arthritis, which is usually very slow, may take years together, but then in young individuals, in high demanding patients, they do require these interventions. So, and the another question I think here is that about the scaphoid fracture. Yeah, most of the times we don't see fracture lines, but clinically we assume, we diagnose that there is an suspected scaphoid fracture. So in such cases, if we don't see a fracture line on an X-ray, but clinically there is a suspicion of a scaphoid fracture, in that scenario, we give a splint for 1 week and repeat the X-rays after a week. 1 week we see, usually most of the times the fracture line is seen after a week or at the max 2 weeks X-ray. And if the fracture line is seen, it is recommended to fix the fracture even if it is minimally displaced, because the results of internal fixation, so percutaneous fixation I'm talking about, is very much better than conserving them, because what literature says is that even the undisplaced fractures may go into non-union, especially waist and proximal pole fractures, because of the inherent blood supply we know about. So if at 1 week also there is a hairline, the fracture is not seen, then you can continue the cast for maybe 3 to 4 weeks and then remove the cast and repeat X-rays. Another important question what you asked is whether to do a CT scan or an MRI. I think if we have to diagnose the acute scaphoid fracture as early as possible, the MRI is the best investigation. MRI is around 95% sensitivity for diagnosing occult fractures. So even at 24 to 48 hours of occult fractures, if it is not seen on X-rays, MRI is a better investigation than a CT scan to diagnose those fractures. But however, we are not practicing that. We don't do MRI. It is better always to give some splint, let the edema settle, the swelling settle, the pain will go down. And after a week or 10 days, you will be in a better position to examine such patient clinically, as well as X-rays. Plain X-rays will also give a better view. Getting 4 X-rays is important, both oblique views, supination oblique and pronation oblique, and a PA view in ulnar deviation. They are good enough to diagnose any kind of a fracture at around 1 or 2 weeks if it is not seen initially at the presentation.
Thank you very much. Another more question. The case you present with Leonate dislocation.
Right.
Do you have a long follow-up for this patient, looking for a vascular necrosis of the Leonate, and is it common or not after this neglected, especially neglected dislocation?
We have long follow-up of many such injuries, maybe 8 to 10 injuries in last couple of years, and surprisingly, none of them have gone into avascular necrosis. The long follow-up, 1.5 year to 2 years follow-up, none of them have gone into AVN, which again, I think that suggests that what we see as skin box disease or AVN of the lean, the etiology of that has more to do something with the development, with the negative ulnar variant, or with its inherently precarious blood supply, and nothing to do with optic dislocations of the lunate as such. Because most of the cases which we have seen, complete dislocation lunate relocated after 2 to 4 months, but still they do maintain that height, they never collapse and don't go into AVN. That is, I think, what we have seen.
Thank you. Shukran. Thank you very much.
Thank you so much. Thank you so much.
Thank you, Dr. Walid. I have a question for you. What about TFC injury?
Yeah,
If you're facing, we are facing many cases of neglected case of TFC injury.
TFCC injuries.
How
Yeah,
can you manage neglected cases?
see, TFCC injuries, I think clinically, they're diagnosing them. One of the very important tests is a foveal sign. Like this is an ulnar snuff box. We can see. We know about the radial snuff box. The ulnar snuff box, that is between the FCU and the ECU. That hollow space. If there is a tenderness there, that is one of the surest diagnostic sign of a TFCC injury. Again, in acute TFCC injuries, they heal very well in above elbow cast in supination for 4 to 6 weeks period of time. Most of, maybe I would say 60 to 70% of these injuries do heal, even if they, not, I don't think doing a primary MRI at the time of injury is mandatory, because that will blow up everything, and because of edema uh, and some synovitis inside, that does not give us a good picture. So treating them conservatively initially is the key, and later on, maybe down the line 2 to 3 months, if they continue to have pain in pronation supination, in ulnar deviation of the wrist, then what we do is we do an arthroscopic diagnostic arthroscopy to see the integrity of the TFCC, and if required, it is repaired arthroscopically. Of course, after doing MRI first, to see whether it's a partial tear or it's a complete tear. Usually the tears which are on the tip of the ulnar styloid don't require any intervention, but the larger tears which are on the base of the ulnar styloid and on the ulna, they don't heal, and most of the times they require arthroscopic debridement there, and freshening of the edges, and fixing that remnant of the TFCC to the footprint with the anchor sutures, or pull out sutures or something like that. And again, post operatively, keeping them in above elbow cast in supination for a period of 3 to 6 weeks.
Thank you very much. Thank you.
Thank you.
Dr. Mawad, I have a question for you, Dr. Mawad. Dr. Mawad.
مع حضرتك يا فندم. Ask Dr. Muhammad.
Yes. Most of missed spine injuries in polytraumatized patient. So if you diagnose a fractured spine, example cervical spine or dorsal spine, you need to put the patient in prone position to manage. And in polytrauma patient, usually you can find fractured femur, fractured tibia. And so how can plan for the patient? Are you starting with fractured spine, which is the more dangerous, or the fractures in the limbs to minimize the patient injuries? What you can plan, please?
Thank you, sir, dear Professor Dr. Muhammad Negm, for your serious questions. As we regard the only urgent in the spine is progressive neurological deficits.
Yes.
This is the only urgent for the spine. So we assess the patient. If there is priority for the spine fixation without any urgency in other extremity fracture, we start from the spine. Like a lumbar fixation, start with lumbar fixation, then we can start with fracture after that with bone leg fracture femur like this. If I can proceed the patient with fracture extremities or have priority, we can, with general anesthesia, start fracture extremities, but with precautions for the spine, like thoracolumbar orthose or brace, with general anesthesia. And we see the case of ankylosing, I speak about it, the patient has both bone leg open, but the spine was missed, was neglected.
Yes.
So after spinal anesthesia and with the flexion of the patient, injury to the cord occur, and this is problematic. But in cases like cervical fractures, we can start if urgency with cervical fixation, then with extremity fracture.
Thank you, Dr. Muhammad Mawad. Actually, I facing a case of tandem fracture spine, fracture cervical and lumbar spine. So we're facing a problem. We need to fix the cervical in supine position and the lumbar spine in prone position. So after the patient taking anesthesia, we starting for in supine position for fractures cervical spine. Then we put the patient in prone position and go from back to do fracture fixation of the lumbar spine. So at the end, have you any question? Any question, please, from the audience? So we can thank all. This is a question from Dr. Muhammad Amir. Is a routine CT enough to detect posterior ligamentous injury, Dr. Warid? I will see his question in chat. Is routine CT enough to detect posterior ligamentous injury? Oh, this is for Dr. Muhammad Mawad, sorry.
Spine.
Yes.
Yes,
Dr.
sir.
Muhammad Mawad.
Yes, sir. What's the question?
Is routine CT enough to detect posterior ligamentous injury?
We suspect posterior ligamentous injuries. I see from the X-ray AB view. If I suspect this MRI not for posterior ligamentous injury, MRI for cord injuries.
Yes.
Ligamentous injuries can be detected from CT, not need for MRI. The rule of MRI in fracture spine not to detect ligamentous injuries because ligamentous injuries appears as a separation of the spinous process with widening.
Yes. Even in plain X-ray.
Even in plain X-ray.
Yes. Thank you.
MRI only for cord. Yes, sir.
Anyone for another question? So I think we became late for Dr. Warid across midnight. So at the end of this webinar on Zoom, I want to thank Dr. Warid I thank you very much for your lecture and the presentation. We learned a lot from this presentation. And thank Dr. Mawad and thank all audience. And we see you again in next Zooms. Thank you all.
Yeah, I would like to thank everybody for organizing a very, very wonderful webinar. Very informative for all of us.
Dr. Abu Saud, thank you, Dr. Abu Saud.
Thank you, sir.
The soldier.
Thank you. شكرا أبو سعود.
Thank you very much for you. And thank you for honoring us, Professor Abdullah and Professor Isa. We are very glad to see you again, and hopefully we can join on Wednesday in Wednesday webinars. Hopefully you can attend with us, Dr. Warid.
Sure, definitely.
Okay, I will keep you posted, and hopefully we can see you here in Egypt physically, not only on.
Definitely. Looking forward. Once this pandemic is over.
All of us are looking forward. Thank you.
Thank you.
Goodbye.
شكرا.
Nice to meet you.